Good afternoon, ladies and gentlemen. I'm Dr. Katrin Schmitz from Mothers2mothers. I'm the Director of Programs and Technical Support and based in Cape Town. In this presentation, I will be sharing with you some of the programmatic learnings and evaluation results of our M2M flagship PMTCT program, which most of you might know as the mentor-mother model. I will give a brief explanation of the mentor-mother model, present the methodology and results of an external evaluation conducted in 2014, and I will conclude the presentation with ongoing M2M program innovation. The mentor-mother model is a peer-mentor approach. Our PMTCT flagship program is a peer education and psychosocial support program. We operate in 6 Option B+ countries in Africa, in Kenya, South Africa, Lesotho, Swaziland, Malawi, and Uganda. M2M mentor mothers are women living with HIV who have recently experienced PMTCT, and we train and employ them to support other mothers and their families through the same process. As those of you in the field know, over the last couple of years, the PMTCT space has significantly changed. Service providers and programs need to be able to effectively support clients on lifelong ART, and we are on the brink of universal treatment. UNAIDS estimates that more than half of HIV transmission to infants in 2013 occurred during breastfeeding. This highlights the need that we need support retention of clients in care and treatment during lengthy periods of breastfeeding, as well as the importance of early infant diagnosis, pediatric case finding, and linking infants and children to care and treatment. In 2014, in partnership with JSI Research and Training Institute Incorporated and the Ministry of Health in Uganda, Mothers2mothers commissioned an external evaluation of the USAID-funded STAR-IC program in Uganda. The purpose of this evaluation was to investigate whether maternal and infant PMTCT outcomes and maternal psychosocial well-being outcomes were associated with exposure to M2M mentor mothers. The evaluation comprised a quasi-experimental matched area comparison in intervention and control facilities. PMTCT outcomes were retrospectively measured, and facility-based psychosocial well-being surveys in intervention and control facilities using a standardized questionnaires were applied among 796 pregnant women and new mothers. Propensity score matching was used to investigate the net effect attributable to the M2M standard of care. The results were encouraging and demonstrated the effectiveness of the M2M mentor-mother model. We measured maternal behavioral outcomes such as disclosure, exclusive breastfeeding, and use of modern family planning, uptake of maternal PMTCT services such as ANC attendance and health facility delivery, as well as uptake of pediatric PMTCT services such as infant testing uptake. Comparison of the intervention and control side showed that the M2M supported health facilities were associated with increased uptake of PMTCT services, especially those focusing on linkages to and retention in care. On all indicators measured except one, we found statistically significant and meaningful results in the hypothesized direction. For example, the M2M mentor-mother model was associated with an increase in retention of pregnant women on ART. There was a net improvement of 27 percentage points among clients in M2M supported facilities compared to those in control facilities. PCR testing at 6 weeks after birth, 6 weeks after cessation of breastfeeding, and 18 months after birth was significantly higher in M2M supported facilities, 26, 29, and 42% respectively. As far as psychosocial well-being goes, the direction and magnitude of the results were equally positive. On all indicators except one, client and M2M supporters facilities showed improved psychosocial well-being. For example, there was a net improvement of 22 and 12 percentage points among clients in M2M supported facilities compared to control facilities on scales of measuring of coping self-efficacy and coping behavior respectively, and a 5 percentage point reduction in experiencing depression. Based on the results, we think that, or we know, that the mentor-mother model is a simple, scalable, adaptable, and sustainable model of peer education and psychosocial support that addresses the challenges of facing HIV-positive pregnant women and mothers. The external evaluation shows that exposure to M2M psychosocial peer support improves the uptake of PMTCT services and helps HIV-positive pregnant women and new mothers and their families cope more effectively with HIV and enhances their psychosocial well-being. The external evaluators concluded that the integration of peer education and psychosocial support into clinical PMTCT standard of care is recommended. Informed by the results and learning across all of our 6 countries and responsive to the change in the PMTCT landscape, we continue to innovate. We have extended our standard of care from facility to community. We have integrated early childhood development services and are aiming to fully transition into a comprehensive RMNCH program. A key target audience are adolescents, and we are in the process of designing our adolescent health intervention, as well as continuing to improve current systems to support the comprehensive and integrated service delivery. A large team of people are behind these accomplishments. The M2M mentor mothers are at the forefront of the service delivery, with the M2M Uganda country team and head office technical support team right behind them. I would like to acknowledge the contribution of JSI and the Ministry of Health Uganda for supporting M2M and this evaluation. And lastly, without the contribution of the external evaluators led by Dr. Charlotte Moheki, I would not be doing this presentation today. Thank you to our key donors for their financial support, and thank you for listening to me for the last 7.5 minutes.